Our next speaker, I'm so delighted to introduce you to Sonji Clarke of Force. Dr. Sonji Clarke is a high-risk obstetrician with a long interest in psychosocial complexity associated with pregnancy. Born in London, but of Jamaican heritage, she is very pleased to be able to attend UWE again after 36 years. Let's welcome Dr. Clarke to speak to us about the importance of advocacy, equity, and cultural competence in maternity. Sonji.
Okay, I'm not going to be as stush as all the other speakers have been because that's not how I roll. I come from southeast London. I'm proper. My mum and dad are Jamaican, and we don't Okay, so they've given me the topic of advocacy, cultural competence, and equity, and it's a topic that's really dear to my heart. So I'm going to try and illustrate it by going through a case study. And this is another one of our cases. Dirty washing. So it's a 27-year-old woman who is married. She was born in East Africa and migrated to the UK a few years ago. She's partially sighted. She's Gravida 4, Para 3 at the time that she started her pregnancy with us at GSTT, or Guy's and St Thomas's. Note that she's only 27 years old. At 28 weeks, her hemoglobin level was 78 grams per litre. But that was part, and she had several missed appointments or did not attend, which were not adequately followed up by our midwifery teams. She also had previous social service involvement in association with concerns about childcare. And her family, including her husband, lived in a 2-bedroom property which was a converted garage. So a couple of weeks ago, she was admitted at 37 weeks gestation after her midwifery appointment at 36 weeks, having not appeared in the hospital for a couple of months. She was discharged from that admission following an infusion of Ferinject, or intravenous iron. And although it was noteworthy that her weight at booking was 40 kilograms, okay? So she had a body mass index of less than 17 at booking. Nothing else was done. She didn't have a weight while she was in hospital. We didn't refer her to the dietitian. She had no anesthetic referral because she's less than a 12-year-old child's weight, and therefore you would be thinking about you wouldn't be giving her 1 gram of paracetamol, for example. She had no hematology referral despite this unexplained hemoglobin of 78. And actually, before she had the Ferinject infusion, she was found to have a hemoglobin of 75. And she was discharged. It was also noted at that point that her last delivery, which had taken place at 17 months before, and it was emergency cesarean section for an abruption. She hadn't been seen in the obstetric clinic to discuss this or plan mode of delivery, but at the point of being seen in the antenatal ward, she wanted to have a vaginal birth after cesarean, which we call VBAC in the UK. She appeared to have a poor understanding of English, and therefore an appropriate interpreter was required for every consultation that she had, or that we as healthcare professionals had with her. Trust me, there was no conversation about contraception. And for me, that's a big miss. You see this woman, she can't really afford to keep herself or her children. Maybe she DNA'd because she couldn't pay transport fare. Maybe she DNA'd because she was so poorly sighted that she couldn't see to catch a bus or to get off the bus. Maybe she was so poorly sighted and so inadequate at actually managing in communications in English that she didn't understand when her appointments were. No conversation about contraception to help her sort of manage the rest of her life and support the life of her children. So, cultural competence, right? So remember, this is about cultural competence, equity, and advocacy. Has anyone heard of cultural competence before? You see, new word. So cultural competence, I think, in 2024 is an incredibly important concept for us as healthcare professionals to get to grips with if we're going to treat our families and our women with equity. What does it mean? So I'm going to just read out the definition. Cultural competence in the healthcare context is an ongoing capacity of healthcare systems, organizations, and professionals to provide for diverse patient populations. And the care needs to be high quality, safe, patient and family-centered, evidence-based, that's what maternal medicine is all about, and equitable. In the UK, we are inspected by the Care Quality Commission, and the Care Quality Commission describes culturally competent care as culturally appropriate care. And they would define it as sensitive to people's cultural identity or heritage. It means being alert and responsive to beliefs or conventions that might be determined by cultural heritage. I think that's only a smidgen of what cultural competence means. And what both of those definitions have failed to do is think about the cultural competence of the patients and families that we are dealing with in relation to our healthcare systems. So, cultural competence and the patient, is it a thing? How do we ensure that the patients that we are dealing with are culturally competent? Okay? Because all of our healthcare organizations have a culture. Okay? We have a way of doing things. We have expectations that we expect our patients and their families to know about, and therefore we expect them to do and to follow those expectations. But it is as the people holding the nexus of power, it is our responsibility to enable them to be culturally competent. And for us in our maternal medicine networks, that's one of the reasons why we are very careful and we think it's really important to listen to the voice of the women themselves who will be using these services. So, healthcare organizations and systems have a culture too. And how do we then provide insight into the culture? Well, we need to ensure that our websites and the way that we communicate with our patients are up to date and using non-jargonized language. In the West Indies, how many of you are using things like Instagram, Facebook, and so on to inform your patients about what's going on? Just give me a show of hands. Okay. So in some of our areas in the UK, we are still sort of lagging behind on giving access to our patients and families about what's happening through those media. Okay, but social media is what our younger patients are looking at all the time. Have any of you seen the tweets regarding the management of nausea and vomiting in pregnancy and hyperemesis guideline that has recently been published? Okay, so it's a way of getting information out to the people that we are caring for really quickly and enabling them to actually participate actively in their own care. We need to have accessible and wide-ranging interpretation services. They need to be available for verbal interpretation, via video, written translation through our websites and other means, but also, do you think about sign language? If someone is deaf, how do they get access to the information? This partially sighted woman, did we provide verbal instructions in her own language that would enable her to understand exactly what was expected of her? And then we need to be inclusive. Patient and family advocacy through service groups to help shape the services, but also inform the families that are being served. So because cultural competence is such a new thing, you will find lots of papers and some books about cultural competence relating to healthcare, but very little on what it means from the patient point of view. But you heard it first here. There is a continuum of cultural competency. So many of you would have listened and observed the big thing that came out in 2019 regarding 5 times more deaths in black women compared to white women in the UK. It's embarrassing because it didn't just happen in 2019. This was going on for, some Jamaicans would say, years. Some people would say years, but for a long time. And why did it get to that point? Because we just ignored it. Because it was black women. We didn't need to act. But since then, it's now come down to below 3. Why? Because we've taken notice and we've acted. Just as you have acted in Trinidad and Tobago, just as I am hoping through WISOM that the rest of the West Indies will begin to act with competence and verve now that we have set up WISOM. So I would say that in the UK, our healthcare professionals and our systems are not culturally competent yet. We've moved from cultural blindness, because people wanted to deny the 5 times more. In fact, people even want to deny it today. But the evidence is there for all to see. We are now, I think, at cultural pre-competence, and we're moving to cultural competence. And it's not just about race. It's about age. It's about neurodivergence. It's about Hindu, Jew, Christian, Muslim. There is a whole range of diverse issues that we need to be looking at. So let's come to advocacy. We're nearly there. I would say that advocacy has traditionally been thought of within the obstetric and gynecology field as the realm of midwifery and nursing staff. And I would like to disabuse you of that idea, like right now. We are all supposed to be advocates for the women that we serve and the women that we care for. We serve them. And holistic care necessitates that we make risk assessment, good risk assessment at every contact, so that we are able to adequately address the needs, both physical or clinical and psychosocial, of all our patients, and that means both mum and baby, but also the families that they are either going to become or that they are already in. And this takes time, but trust me, it saves lives. And to be an advocate, to practice advocacy, you need to be able to speak the truth to the system, to the organization, to the culture, to the women and their families, and you need to engender trust. Your patient needs to understand what you are saying and what you are doing and why you are doing it, but you need to understand them. And fundamentally, that means that we have to act with compassion. Without compassion, you're going to sit back and allow 5 times more to continue. With compassion, you act and you make a change and you save lives. So lastly, we come to equity. You will not get equity. You will not achieve equity for our women and their families unless you develop cultural competence. You practice advocacy and treat them holistically. You make proper risk assessment so that you can act properly. Unless you are clinically and psychosocially competent, and unless you are compassionate. Because if you are not compassionate, if you don't care, then why are you going to act? And what are you going to do? So what happened to our woman? She attended in labour, but from the very beginning of her labour, she was having decelerations in her, with her cardiotocograph trace. And for me, red flag, because she's a VBAC. She's had a previous cesarean section. And more than that, it was only 17 months ago. So she was taken to theatre with a virtual interpreter at 3 o'clock in the morning, and I was called in. At the time, she had a hemoglobin of 84, and she was therefore transfused intraoperatively. And when they opened the sheath, the baby was saying, "Hi," because she'd already ruptured her uterus. And I want you to note that her post-delivery weight was 42 kilograms. How is she going to have musculature in the uterus that is going to withstand a labor if she is malnourished? It's not going to happen. So we had multiple missed opportunities to make an intervention with this patient. She had poor advocacy from all members of the team that should have been taking care of her, but particularly those that had contact with her. The risk assessment was poor, and we didn't act adequately antenatally. There was poor cultural competence in both the mother and the family that meant that she didn't attend her appointments. And from our point of view, there was poor cultural competence because we didn't understand why she wasn't attending her appointments. The clinical care was therefore, if she was someone that went to the Embrace report, they would say that if she had died, it would have been preventable. And there was clear psychosocial complexity, which we know adds to the risk of maternal morbidity, but particularly maternal death. And all of these things contributed to what I would class as a near miss. So what do we do to prevent this happening again to this woman and others in future? Well, one of the things that we will do, and we have done, I believe, is put a long-acting reversible contraception in her arm before she leaves hospital. We have also suggested that she doesn't leave hospital until she has been seen by the dietitian and she receives supplementation so that she can develop a proper weight before she goes home. But this could all have been done by the contraception antenatally. So I would like to call all of you in this room and those of you who are listening across the Caribbean to action. I would like to say that equity, advocacy and cultural competence for healthcare professionals, healthcare systems and patients is essential for maternal medicine networks and services to be effective in keeping our women and families safe. Contraception, contraception, contraception. Adequate contraception prenatally and postnatally is absolutely key to protecting our women and children, allowing education, allowing financial stability, allowing life and healthy life for those who are clinically and physically vulnerable, as well as those who are psychosocially vulnerable. It must be, and Kathy knows that this will frequently be a question in our maternal fetal medicine ward round. Have you had a discussion about contraception with this woman? Because it might save her life. If we don't, then all of this complexity begets further psychosocial complexity, and we will be in a downward spiral. It is our responsibility to get this right. Thank you.